can try alternative number, Chair.
Yeah. The challenge is that we need to be both managing this meeting, but I have not been able to discuss with her.
I will try on another number, Chairperson.
Honorable members, we need to start. And we all got, I don't know, there's a noise that is, thank you very much. Can we agree that we will go to mute and only be able to unmute once we present or we ask questions? Welcome to all members. We had thought that this was going to be just two presentations, which we still have to do. Netcare and Life Group, was there are similar programs of those private hospitals. But however, there has been something that is running in the country which is urgent, and it's a concern regarding the backlog of NHLS. We just thought, therefore, it would be important for members to get an update on this matter. I have since spoken to the CEO of NHLS, Dr. Kemi Chetty, who I see she's ready to present. And I said to her, thank you very much for sending the presentation early yesterday so that we're able to send it to members. Therefore, she needs just to summarize, focusing on what has actually been our challenge. NHLS is one of those entities that actually report to Parliament via Department of Health. So we already know them, but there's been just this recent challenge that we would like to have updating us on. That will be our first item. But maybe let me just, before that, check with Ms. Machalamba if there are any apologies that she's aware of. Okay, she will probably send that to me by SMS or WhatsApp, because I notice she's on and off in terms of the challenges with the connections. Can I therefore start and request the first presentation? I have really been discussing with the members time allocation that at 4 o'clock we will have to stop that part. If there are questions that are not answered as yet, Dr. Chetty, you will answer them in another form, but we'll have to move on to another presentation of Life at 4, and then at 5 o'clock, Netcare. If I were then to allow Dr. Kemi Chetty, this platform is now yours.
Thank you very much, Honourable Chair and Honourable members of the Portfolio Committee. I'm just going to share the presentation. Can you see the presentation, Chair?
Yes, we can.
Okay, so thank you very much, Chair. As you indicated, you don't want me to go through any of the details. Everyone is aware of the National Health Laboratory Service. And maybe just to start with the, oops, just go back. So, sorry, Chair, I've just skipped a file. Yeah, I can't see the... Just for the first one. So Chair, just to say that in the NHLS has been increasing the number of tests on a month-to-month basis, and you can see that there's been quite a massive increase of the number of tests that were performed in May. In April, we did about 95,000 tests. In May, that was more than doubled to 232,000. And in the first week of June alone, we did 105,000 tests. So you can see that we've been increasing the number of tests that we're doing. And this slide gives the breakdown of the number of tests per province. I'm not going to go through each one, but you can see that the highest number of tests that were done is in Gauteng, and followed by the Western Cape and then the Eastern Cape. But the positivity rates between the provinces differ quite a bit, because the Western Cape is the highest with regard to the positivity rate. But you're well aware of these issues. This just gives us an example of the number of tests that we're doing on a daily basis. And again, this is just the number of tests per week. And you can see that almost every week since we started testing around the 8th of March, that we have been doubling the number of tests that is done within the NHLS. The last number is basically the tests that we did yesterday for this week. Chair, you had wanted to know about our capacity for testing. Just to remind the members of the committee, so basically there's two processes that has to be undertaken when we collect the specimen. One is the extraction of the RNA from the virus, and then once that is done, we then do what's called an amplification of that RNA, which we convert into a DNA, and then interpret the results. Now, the reason as to why I've elaborated on that is that we've got two types of machine. The one is a separate a machine where we have separate extraction and separate the amplification. And these are what we call our open platform machines. So it's a long, tedious process, because we take the virus out, we then take that sample, and then we put it into the PCR machine in order to get the test done with regard to amplification. So the throughput for these machines is not that high, both because the extraction of the virus takes some time, and you can't do that many within an hour. The second types of machine are what we call our integrated automated machines, where the machine itself does both the extraction as well as the amplification. And these are high throughput machines, which is the Roche Cobus and the Gene Expert. The Abbott M2000 is, whilst it is an integrated machine, the throughput is not as high as the other two machines. And then, so these are the machines that we've got. I'll go into the details about the machines that we're going to get. The reason as to why I was giving that explanation is to show you that when we with our separate extraction and PCR platforms, those machines can do about 5,000 tests in 24 hours. With our high throughput machines, they can. This is the machines that we use for the viral load, which is the Roche Cobus, and then the Gene Expert we use for our TB. We've looked at the spare capacity with those machines, and together we've got 15,000 in 24 hours. So that's where the number of 36,000 comes from. It's a combination of all of those machines. And that number represents the capacity that we have, which means it's the throughput in the machine. So the machines are capable of doing those number of tests in 24 hours. This just gives you an idea of the distribution of those machines. Northern Cape isn't here, but that's something that we'll be looking at going forward. So this just roughly gives you the idea. Then these are the number of extraction machines that we've got in the different provinces. And the reason as to why I'm elaborating on this is to give the committee an idea that with regard to our open platforms, We have got on hand, we have got a lot of kits, that's over 500,000. That changes as we use up the machines, but we still got a good supply of that, and we know that we will also be able to get those kits from our manufacturers. But where the problem lies is in this area here, where on a weekly basis we are getting 10,000 kits from Gene Expert and 10,000 from Roche. Roche has slightly improved it now to 19,000, but it's not guaranteed. Gene Expert has been saying that they are going to be increasing the amount. That hasn't happened as yet. And this is where our limiting factor comes in, is because we were expecting that 15,000 per day, as I showed you in the previous slide, but what we're getting is that number per week. Okay, and so that's where our capacity problems have come in. This is the other capacity problem, is that whilst we've got a number of PCR kits, as I've shown you, it's the issue is the extraction, because internationally they're short of extraction kits, and so the suppliers, and you can't get other suppliers, you have to go to these suppliers. The suppliers ran short of kits, and they've indicated to us they're not able to get any more than what they're getting. Over the last 3 weeks, we've been improving on the number of kits that we've been getting from Nimbus, and that has impacted, as you see, on the numbers that we are putting out, because at least we are able to do a lot more because of that. So, Chair, this is where we are with regard to the backlogs. We had a very difficult time during May. It's been a very difficult period because the number of samples we're getting on a daily basis was increasing rapidly, but it was the same time when the suppliers started running out of supplies, and so that's where we ended up with a huge backlog. But as you can see, we've been processing those backlogs down, and as we stand now, it's about 63,000, but we'll be improving on that quite dramatically. So this gives the breakdown then per province, and what we've been doing is systematically working through the different provinces. We have prioritized the Western Cape because of its high positivity rate, and we know that what happens in the Western Cape now is going to impact on the other provinces. So as a result, we have been giving them extra kits in order to reduce the backlog. That's the high throughput kits, but we still have been making sure that we cover all the other provinces. So Western Cape, we've reduced the backlog from about 18,000 and 15,000 the end of May, and you can see we've radically reduced the backlog to where it stands today. It's the same in the other provinces. We still have a challenge in the Gauteng province, and we're busy trying to sort out the backlog. The other priority province for us is the Eastern Cape, where we've brought in a whole lot of new equipment in order to sort out the challenge in the Eastern Cape province. So what we've done is we've got testing priorities, where we prioritize testing for those with the medical need and for clinical diagnosis, then testing for high-risk individuals, testing of critical frontline workers. The surveillance hasn't come in yet. I'll talk a little bit about it towards the end, and then screening and targeted hotspots. So Chair, just to say that with those categories, we've color-coded it, and we've improved on the workflow. So we've been trying to make sure that we prioritize the in-hospital patients. This is an example from Western Cape. We've looked at the turnaround times for the hospitals in the Western Cape for the inpatients, and we know that that the results get given within 24 hours. So this is the average. In some instances, it's a lot less, and you can see that our turnaround time for the in-hospital patients. So the point that I want to make here is that our backlog is mainly in community screening. The hospital patients who are at risk and who need a clinical diagnosis, we make sure that they prioritize so the backlog does not impact on them. Okay, so we make sure of that, and that's why we've tried. We're categorizing the patients now, so we can assist in getting that prioritized. This just gives you an example of we looked at the number of platforms that we had. So one of the strategies that we use is we started off with standardization, and then the standardization was a problem because if one company couldn't supply us with the kits, we came to a complete standstill. So we decided to diversify our platform, and we've been buying and we've procured a number of equipment much earlier on. The lead time for these equipment is very, very long because of the lockdowns in other countries. So we did procure it some time, but we're now in the process that during June, there's a lot that we've installed and we'll be installing more. So we've bought a whole lot of additional equipment in order to diversify the platforms. So we also make sure that one lab isn't just dependent on one type of machine, because that's where the problem comes in. So we're giving them a whole range of different machines, dependent on the size of the laboratory. Okay, so I've spoken about we've increased the number of extraction equipment, we diversify the platform. What has really helped us is that our experts have started working on alternative methods of extraction. So we're using which the experts have been working on for the last few weeks, and it's now working quite well, and that has also helped us with the numbers that we're putting on. So things like heat activation and lysis, and we're also using pooling as well, and this has helped us with to increase the throughputs. We also bought extra PCR equipment. The minister himself has been involved in really talking to a number of the suppliers in order to improve our supply. So the issue isn't, we've stabilized the finances of the organization. We've ordered the equipment. We've ordered the kits. It's just that the suppliers just don't have enough kits in the world. We're also looking at more targeted and focused testing. And we're also then looking at the use of rapid diagnostic tests. There's two types. One is with the blood sample, where we take the blood sample, we put it into the machine, and it checks for antibodies. And there's three that we're validating at the moment. There's one rapid test that meets the criteria for sensitivity and specificity, and we're validating that as well. We've asked the supplier to get us the kits so that we can validate it. We're also working closely with the private sector as well as the academic sector, but their capacity is also very limited. The problems that we're facing in the NHLS are exactly the same problems that the private sector is also facing. Just to say that we've had support from a number of organizations, and the president as a president of the AU has also announced that they're looking at getting extra kits. The Department of Agriculture and Land Reform has also given us RNA extraction platforms. We've had help from the WHO, the CDC, a number of foundations, and as well as the Solidarity Fund, including Orlando Pirates and the Kaiser Chief, and a number of different organizations that has been assisting us. I'm not going to go through the details, Chair. You can. The committee has got the report, but for each of the different provinces, we've worked on a strategy in order to be able to meet sort out the backlog as well as to meet the surge requirements. So I'm not going to go through those details, Chair. Sorry. Just go back. In conclusion, Chair, so we've upscaled our capacity in order to not to, and we've done it also just to make sure that we don't rely just on those high throughput machines, because we've been very disappointed with the numbers that we've been getting from there. So we're trying to improve our capacity in order to meet that demand. And you can see that we have been increasing it. And I thought it'll just be useful. We've just given you slides just to show the number. This is just for the month of May. So we've grouped together the provinces of Western Cape and Eastern Cape as our priority ones, because you can see that the positivity rates is quite high in these provinces. So the bar indicates the number of negatives, the blue little thing shows the number of positive cases, and then that's the red bar indicates the positivity rate. Gauteng and so just go back. Gauteng and KZN is whilst there's a number of tests that gets done and a number of positive cases, the positivity rate remains fairly stable between 1 to 2%. With regards to the other provinces, Free State, Northwest, and the other provinces, you will see that there's a number of days where there's tests that get done and there's 0 positive cases. And positivity rates, they are below 1%. So that also includes in Mpumalanga and Limpopo. There's a number of days where there's 0 positive cases. So we are keeping a very close watch on all of these cases. Northern Cape, we've been monitoring it because of the increase in numbers in these latter days. And as I indicated, we want to capacitate the provinces there. So Chair, when do I stop sharing?
Thank you, Dr. Chetty.
Yeah, we just want to stop the sharing, yeah.
Get your pen and paper to take comments and questions from honorable members. Thanks for your presentation. We are going to request that honorable members, you give each other a space also to ask. The order of asking questions is going to be as I have received it in this way.
Sorry, Chair. Sorry, Chair, can I just, the chair of the board for NHLS was going to join us. I'm not sure whether he's managed to connect. It's Professor Eric Book.
Yes, I am here. I've been here from the start.
Okay.
Thanks, Chair.
Welcome, Professor Book. We'll ask questions because you're a professor. You're going to answer the difficult questions. Let them start. Order of asking questions in this way: Honorable Janji, Honorable Imam Sheikh, number 2, number 3, Honorable Van Staden, number 4, Honorable Gela, number 5, Honorable Kenny Jacobs, number 6, Honorable Wilson, number 7, Honorable Kwahube, number 8, Honorable Ismail, number 9, Honorable Sokacha, number 10, Honorable Chirwa. I have received also another one saying Honorable Malika would like to ask. But when you ask questions, honorable members, please be mindful that you still have to give other colleagues a slot. I now see other members coming in from NCOP who logged in late. Honorable Malika would like to ask Honorable Baha and Honorable Christians. But if time allows, because I will have to stop Dr. Chetty at 4 o'clock. Whether she has completed the answers, then the rest you will have to follow them behind. Mamu Shlengwa, there has been a procedure how to raise your hand. I've asked you to follow that procedure. use your gadget where I've asked you to indicate your desire to put. I now see you raising the hand there. Then Mam Lisheng will be number 11. Thank you. Start, Honorable Janji, and you'll follow one another. You know your numbers now.
Thank you very much, Honorable Chair. Let me appreciate the presentation from Dr. Chetty. I guess, Chair, more than a question, it will be a comment. We appreciate that NHLS is doing so much to work on the backlog. But my plea would be that these two provinces that she says they've prioritized, can they really look into it, because those provinces are having a surge before others are having a surge. So that would be the plea, and that we would like to see more of the recruitment of staff, so that you do not give the machines to the laboratories and there's no staff to do the test. Thank you very much, Chair.
Thank you very much, Chair. I think I'm next on the list. Chair, first of all, allow me on behalf of the National Freedom Party to extend our condolences to the family of the late Honorable Dora Dunana Dlamini, our colleague that succumbed last night, who passed away. May her soul rest in peace. Thank you very much for the presentation that you have made. Now, one of the challenges that I have, and particularly the National Health Laboratory Services, and that is at the Tygerberg facility that you've got. And I know that you're inundated and you're under tremendous pressure. We accept and understand that. One of the problems I have, and I have written to the laboratory there, I've got a first response and thereafter nothing. And this is my problem. Tests are done right up to the 8th of April. 8th of April. Results are not forthcoming. Then people are going back there to the laboratory. They are given letters to go back to work, and if they pick up any symptoms and things, then they must come back. Now, my question is that would the period of time between when the tests are conducted and the results that are being released, and particularly after the 14-day period, people are going back to work, particularly in the major retail sectors. My concern is the risk attached to this in the delay that is caused by the National Laboratory Services in being able to give the results timely. I'd like you to comment on that. Thank you very much.
Honorable Van Staden.
Thank you, Honorable Chairperson. I have just two questions. One is on slide 4. You have a number of 1,171 inconclusive tests. So this means that there is this number of tests that cannot be clarified if a test is positive or negative. I just wanted to know, just clarify with me, what is the reason for this, and what is the cost to conduct one such a test in your laboratory? And then my second question on slide 14 is the unprocessed specimens, the figure you showed now for 63,000. Is it correct to say that if a specimen is older than 3 days, that is actually useless and that you can actually get rid of it? Please correct me if I'm wrong in this matter. Thank you, Honorable Chairperson.
Okay. Honorable Kela.
Thank you very much, Chair. Let me also pass my condolences to the family of Honorable MP Dora Dlamini. May her soul rest in peace. Chairperson, my question is on the distribution of PCR equipment to provinces. I know that the presenter indicated that they've excluded Northern Cape. I just want to check, because we've got 9 provinces. I want to check with her why they've excluded the Northern Cape province for receiving this machine. It's because of maybe there's no need or what. If we can get a thorough explanation why Northern Cape was not included. The other question, Chair, I agree with the strategy to prioritize who gets tested. I just want to know, how does the how does this relate to the strategy of NHLS to upscale the number of tests, since the need will be greater as we go forward? That will be my question, my second question, Chair. Thank you.
Honorable Jacobs.
Thank you, Chairperson. Thank you very much for the presentation, CEO. And let me also express my condolences to the family of the honourable member who passed away last night. My question is two questions. One is related to slide 4, which speaks to the number of tests done in the Western Cape, and I'm going to compare that with Gauteng. And I'm a bit concerned if I look at the number of tests in the Western Cape of 114,381 as on the 8th of June, as compared with Gauteng at 151,954, yet the positivity rates are so dissimilar. It does really not speak to each other. So there's a question that needs to be asked here. Has this to do with strategy? What is the real answer behind all of this? And how do we correct this type of testing in line with the fact that we do not have the adequate number of testing reagents and testing kits, etc. So somewhere we need to improve on the situation. We also appreciate the suggestion of reprioritization of testing, and I agree with the strategy. I just want to ask, in line with my first point, is would that reprioritization be uniform for all provinces? And my second point also related to the backlog on unprocessed specimens, and Honourable Gela just spoke to it now. But Honourable Van Staden, the real question here is there any value in still doing tests which have been in the fridges for the past 2 weeks? And how do we align that decision with what it is that we want to achieve? I think primarily we want to achieve the identification of the persons having been COVID positive, number one, and number two, who have active disease, and number three, so that we can get a clinical diagnosis and get our treatment and intervention options prioritized. And not really epidemiological value would be important, but I think in the situation that we are in, and with the surge that is happening, I would like you to maybe address those questions. Thank you very much.
Honorable Wilson.
Thank you, Chair. And again, from our side, condolences to our colleague who passed away so suddenly last night. Our prayers are with her family, her friends, and her colleagues. Thank you, Dr. Chetty. I just have a couple of things, and I'm going to reiterate what the Honourable Jacobson from Staden said with regards to the backlogs, and I hear both of their concerns. I also have a concern with regards to backlogs, because as long as there are these big backlogs and specimens are lying around, we run a huge risk too of contamination of those specimens, and that is a bit concerning for me. And during this whole lockdown process and dealing with throughout the whole lockdown process and the dealing with the pandemic, this has been, it's fallen under the Disaster Management Act. Can you, Doctor, advise which regulations under the Act govern the tests for COVID, if there are any? And can you please explain to us why we get discrepancies in figures from provinces? And I'm just going to highlight one case. It's one of a few that we've got, where we got, for instance, in Limpopo, an area called Maraleng, one day had one case. The following day, when the figures came out, that case had gone. It was back to 0. 2 days later, and the day after that, it was suddenly 2 again. It's very disconcerting, because people are following these these cases, and the progress of the pandemic and infections very carefully. And they get quite alarmed because they're not getting correct figures and they don't know how it affects them. Fear obviously being the ruling factor. And Dr. Chetty, you don't have to answer this today. I don't mind getting it in a question because I'm not sure in a written question, I'm not sure if you were in a position to answer it. But in light of the tobacco case that is in court today, do we have any statistics on how many of our COVID deaths were actually smokers? Thank you, Chair.
Honorable Kwahube.
Thank you very much, Chair, and thank you to Dr. Chetty and her team. Just a few questions on my side. We understand right at the beginning of the pandemic, one of the things that we had said was that the testing capacity needs to be ramped up significantly. And in fact, the department had set a target of testing between 15 and 30,000 tests per day. So I understand that that has not happened. And obviously the backlogs, and I mean, I've seen that, we've hit some around the 20,000 marks, but also the backlogs have now undermined our ability to effectively fight this pandemic when people aren't able to get their results back in time. Now, what I want to understand is what kind of strategies have we employed, particularly, Dr. Chetty, where it comes to developing local and domestic capacity? Because what I understand is that some of these reagents and some of these equipment that we are lacking from the global community are things that we cannot necessarily replace. But then, we've now had 3 months. What kind of local capacity are we building to be able to bring those online? And then lastly, then the question around the gene expert machines. Although I know that they require cartridges, which are also one of the things that we are lacking, what is the criteria used to distribute these machines across the country? So how many are allocated per province, and what's the criteria that is being used there? Thank you.
Honorable Ismail.
Thank you, Chair, and once again, thank you for the presentation. My main concern is the backlogs of results. Basically, it's a nightmare. I've been doing a lot of oversight, and I have health professionals telling me that it's really making no sense. We're testing hundreds and receive no results on time. People have been tested and they've been waiting for results. They went into isolation. They've even come out of isolation, and they've gone back into their places of work, and still. The fact that we don't have results is just putting more people at risk, of getting the virus. Secondly, is that how much does a test cost? I mean, is there any national guidelines on pricing? Because there's a vast difference between the labs charging for this COVID-19 testing. And we've also had issues where patients have gone to be tested, and then they've been told that if they are tested positive, the medical aids will pay, and if they tested negative, they have to carry the burden of paying for the price of the testing themselves. So that is something we need, guidance on. Thirdly, is that I see my colleague have asked that, but I just wanted to know how many patients on ventilators presently are actually smokers. Thank you.
Honorable Sokacha.
Very much, Chairperson. Chair, let me also welcome the presentation made by Dr. Chetty. Chair, I've just noted some few inconsistencies on the information given to us about provinces. The first one, Chair, is around the capacity at the NHLS, the virology laboratories. Honorable Kelly asked that question, where the Northern Cape is not presented there. The second one, Chair, is also around the unprocessed specimens. I've seen there are about 4 provinces that are not included there. And then the other one is around the provincial action plans, where Western Cape, Eastern Cape, Gauteng, and KwaZulu-Natal are the only provinces that are noted there. That is my first question. Why the inconsistencies when we get information about provinces? Then the second question, Chair, is around the test kits. What is the situation? Do we have shortages of test kits, or are we up to date in as far as our test kits are concerned? Thank you very much.
Honorable Chirwa.
Thank you, Chairperson. Condolences to the family of MP Honorable Udlamini. May God be with them during this hard time. My questions are as follows. I want to hear from the NHLS, what is the rationale between or behind procuring laboratory material in Western countries and not procuring them locally, and what the ratio is, what the percentage is of local procured equipment by the NHLS domestically in South Africa as compared to internationally or in other Western countries. I also want to ask, how big is the capacity of the NHLS to monitor laboratory tests done in the country if they are legitimate? Because a lot of concerns and grievances have been brought out to say people have passed on due to different illnesses, but their death certificates are stating COVID-19. What is the legitimacy of the tests that are conducted and the data that is shared by the department through the NHLS? And also, why does the prioritization of testing being done to people who are already in a hospital when those who are outside actually have a higher chance of spreading COVID-19 than those who are already hospitalized? I think the NHLS must relook at this reprioritization, and people who have COVID-19 symptoms who are already in hospitals should be treated as COVID-19 patients from the get-go. And those who are not ill enough, or rather who have succumbed to the illness or the symptoms, who are still outside, should be prioritized because they are more at risk of spreading the virus than those who are in hospitals. And also, we got complaints about the NHLS calling people and asking for 1,800 rand for tests that are conducted in public hospitals. The latest one was from Somerset Hospital. Are these tests not free? And if they are, why do you have a call center established? And lastly, can the NHLS also just tell us why they don't have region-based strategies in conducting tests and responding to COVID-19? Because this umbrella approach is not going to work, and we've raised this time and time and again that you need to have region-based strategies, because these regions that you keep giving them umbrella practices and strategies don't function the same way culturally, socially, economically. The NHLS must break down its priorities and put them in region-based operational centers. We've been saying this. I don't know why it's not yet been done. And I don't want to cite laziness, but there must be more done. I mean, we can't accept that NHLS only has a strategy nationally or provincially when it's not enough, and it's clearly not enough. So yeah, okay. Thank you, Chair.
Yeah. Honorable Mama Sengwa. Ma'am Sengwa, we cannot hear you.
Thank you, Chair. First of all, let me pass our condolences as an IFP to the Dlamini family and the ANC party. Such a loss. That is a sad news and shocking. May her soul rest in peace. And then let me welcome the presentation. Partly my question was, Mama Chanti was asking what I'm going to ask about the recruitment of the staff in the laboratory. But now my worry is that, is there any policy put in place in order to reduce this backlog of testing? Because this testing is down in our provinces. We have done the oversight where we see that there is nothing happening in the laboratory because of the lack of staff, shortage of staff. I thank you.
Honorable Malika.
Thank you, Chairperson. Let me pass condolences to the Dlamini family. May his soul rest in peace. Chairperson, I want to check that does the NHLS have the capacity to monitor whether all the laboratory tests done in the country that are legitimate? And how much has NHLS spent on private laboratories due to shortage of consumables? My last question, there have been complaints on lack of response of inquiries sent to NHLS or NICD. What is the reason for this and what is being done to correct it? Thank you, Chairperson.
Honorable Christians, Bacher first, yeah. Bacher and Christians last.
Chairperson, let me also welcome the report as presented by Dr. Chetty. Just two questions from my side. One, there's been a report that some specimens probably are ferried by road from the Eastern Cape to Gauteng, and I just want to check whether such is a fact, and if it is, doesn't it have a bearing on the inconclusivity of tests or specimens that are received? Two, the second one, Chairperson, is on the backlog itself. To what extent does this backlog contribute to further or continuous infections, wherein people are waiting for results and they still have to then go back to communities and probably spread the virus unknowingly because they might not have received their results back? Thank you, Chairperson.
Honorable Christians, you are the last one.
Thank you very much, Chairperson. My question is just around the procured 67 mobile vans that were deployed to provinces. I think it was early in April. Now, in light of this shortage of the kits currently, what is the responsibility then of these vans that have been deployed to provinces? Are they still adequately capacitated to do their job in provinces? Are they still working? And then also, in which provinces are these vans deployed, these mobile testing kit vans? And how can community members access these vans for testing? And then just a second question, which has been touched by other members, but I'm particularly concerned as I am from the Northern Cape province, is the Northern Cape stats. Now, currently we are on 134 positive COVID-19 patients there, but that doesn't seem correct at the moment. We would like the true picture of the Northern Cape. Just today in the media, the SAPS building has been closed, the SAPS building has been closed in Kimberley, where a high-ranking official has apparently been tested positive. Why has the Northern Cape been excluded, and when will we get the proper information with regards to the Northern Cape? Thank you, Chairperson.
Okay. Dr. Chetty, you will have about 14 minutes to reply. Honorable members, I'm reminded that when you speak, like most of you have done, please switch on your video so that we can see who is speaking and sitting where. You have done that excellently. Continue in that way. On all the things that we have said, I think maybe it would be nice, it would be important that we close the meeting with the statement that we set as a portfolio committee, and we received the bad news about the passing on of Honorable Dora Dlamini, and we express our condolence on behalf of this committee to the family. Thanks. Dr. Chetty, I will stop you at a minute to wrap up, to remind you at a minute to 4. We have a Netcare group coming in to make presentations to us now. Thank you. You can now start.
Thank you, Chair. I'm not sure whether Prof. Book wants to come in at this stage.
No, I'm happy to make one or two comments right at the end, if there's time after you've replied.
Okay, thank you, Chair. So with regard to the first issue that some of the provinces need to be further prioritized, that's exactly what the NHLS is doing, we with the provincial action plans, you can see that we're buying more equipment, we're selling more test kits into those provinces. And the issue around staff getting recruited, we've made this a number one priority. So we've made it very clear to all of our provinces that any staff that's required must be recruited, and this has been happening. And it's not just it's not just the staff in the laboratories. I think it needs to be pointed out that the toll-free, the call centers that we've established was done extremely rapidly within a few days. We recruited masses of nurses to work because it's a 24-hour hotline, and at one stage we were getting over 100,000 calls. So the nurses work in shifts throughout the day. We made sure that there was enough. We recruited doctors into the doctors hotline. We've now got a results hotline that we also have recruited individuals. Over and above that, all of the mobile labs, the mobile vehicles that we bought, we've staffed them with 2 nurses and 1 driver in each of those vehicles at the NHLS cost. So this has been a value add that we've brought in, and we've made sure that all of that gets done. Chair, the second question from member the MP Imam. I'm trying to work out the issue around Tygerberg, and perhaps I'm not getting what the issue is there, because in Tygerberg Hospital the backlog has been cleared. Sorry, I don't have COVID. It's my throat is just need to drink some water. Okay, so the issue there has been as to the risk in giving the results because of the backlog, giving the results that's not time years. Chair, just to say that every person who gets tested should have been tested according to the case definition of being symptomatic or being in contact with somebody who was positive. And every single person who gets tested gets counseled that they need to go into quarantine, right, or isolation, self-isolation, until the 14 days is expired, and that should have been practiced. So that should not be impacting on the individuals spreading the disease during that time. If after that 14 days they would have been counseled, if they don't have symptoms, if they're not sick, then they would be able to go back to work. So the backlog itself should not be affecting what people's behaviors are, because they would have been counseled to make sure that they do practice those safe behaviors. I'm not sure what letter has been given by Tygerberg, so maybe I won't comment on that. The issue from MP van Staden on the inconclusive reports, the issue is the inconclusive reports is normally where the machine itself, which is in some instances the machine has got the software that will say this result, we cannot get a result because they either didn't identify one particular gene and they couldn't come out to say whether it's clearly negative or positive. The labs would contact the individuals or the clinician to say that the test must be repeated. The number that we've got that's inconclusive is not that high. because normally this would happen with a lot of machines. It's where you have difficulty in being able to come out with a clear result from a specimen. And it could also be because of the whether the specimen was adequate, whether they actually got enough of the sputum when they took the swab. And so there's a lot of reasons around that. The cost, a number of people have asked around the cost of conducting one test, and we've estimated the costs differ fundamentally dependent on what reagent gets used, but we've worked on an average cost of 507 rands per person. The issue around if a specimen is older as to what's what's the quality of that specimen, and I need to state that whilst we know that biological samples over time may deteriorate, we also aware that what our results are showing doesn't support that theory. So what we are doing is we're currently conducting an experiment to investigate how long the RNA can be detectable in these samples, and in order to get the evidence, because you can't say there's different papers that have been written that where it's been stated that if you store it in a particular environment at a certain temperature, then it can last for a number of days. So we're conducting tests now in order to look from an evidence base as to how long the samples will last. We don't want to, I know that there's been a lot of theories that are going around that saying it could be 2 days, it could be 5 days. As the NHLS, we believe that the evidence is important, and once we've done that, we'll be able to come back to you. The issue around the Northern Cape and whether it's been excluded, I just need to clarify this. Northern Cape has not been excluded, but just to say that the current platforms that we are using, so most of the platforms, the COBUS, the C-Gene platforms, all of that, except for the Gene Expert, but all the other platforms, the test has to be signed off by a virologist. So the virologist looks at the different patterns because they are testing for different genes. And they need to sign off to say that that's a positive test. And therefore, the test can't be done in any laboratory. It can only be done in laboratories where there's virologists. Now, we don't have virologists in every laboratory, so it can't be decentralized. And in the Northern Cape, we don't have a virologist. But that's why we're looking at a plan of getting a virologist to support the Northern Cape so that we can get equipment there. The Northern Cape does get test kits from the Gene Expert. So that does get included, and I should have put that into the presentation. So the Northern Cape does do some of its own testing, but we're looking over and beyond that of getting some of the other equipment into the Northern Cape. The issue around the priorities for the testing going forward, that's in discussion with the National Department of Health. And once that discussion has been finalized, it will be circulated. The questions from member Jacobs, the issue around the differences in the numbers between Western Cape and Gauteng, until recently, most of the provinces were testing according to the same case definition. And proportionally, if you look at the number in the populations, the Western Cape is doing a lot more tests, understandably because of the number of positive cases, than some of the other provinces. So you do also need to look at population size in order to look at the numbers.
Dr. Chetty, please can you improve your speed?
Okay, thanks. So the reprioritization, I've said will be discussed with the National Department and each of it is a national policy. The issue around risks of contamination with the backlogs, we make sure that there is no risk because it's stored under very careful conditions at a particular temperature. There aren't any specific regulations that relate to the testing. The question from Member Wilson. I'm not sure, Member Wilson, as to what are the changing numbers. The stats that get given out are the stats from NICD, which includes also the private sector. The stats that I'm giving you is just for the NHLS. The issue around stats on smokers has been asked a couple of times. We do not keep those stats as the NHLS. We only keep stats on the tests that get done, not on the clinical history. That comes from the Department of Health. The issue around the testing capacity as of 15,000 and then 30,000, I've indicated that that's the throughput of the machines. But right now, on average, in the last week, we've been doing more than 15,000 tests per day, and we're building up the capacity with regards to the 30,000. But as I've said, it's dependent on the ability to get those test kits. We are trying every means to get those high throughput test kits from our suppliers. The issue around the suppliers is that we can only use the test kits from those suppliers. We do have local manufacturing where there are some companies now that are looking at manufacturing some of the kits. We've got the ability to make those kits ourselves, and we have been doing that, but it's quite time consuming. So that's why it's easier for us to use the ready-made kits. But the Department of Science and Innovation is assisting the SMMEs with regard to the others. The Gene Expert we've got over 325 machines in 171 sites throughout the country, so it's very well distributed, allocated in all of the provinces. We're also getting more of those machines. The issue I've spoken about, Northern Cape. The provinces that we concentrated on are the provinces that have got the high positivity rate, but there are action plans from all the different provinces. The issue around monitoring of data, we've got a very good monitoring system. We've got one of the best central data warehouses, and the data that we've got is consistent. Everybody utilizes it, so it's very good data with regard to that. I'm not sure, please, Member of Parliament, the issue around our call center asking people to pay for tests. I mean, that's not on. And if you've got any information with regard to that, we don't charge for the tests. So please let us know, because I'd like to know if there's somebody who's abusing whatever situation they're in, and we will follow that up. And then just around the recruitment of staff, we've recruited a lot of staff, and I've spoken around that. The testing in the provinces are not down; they've been increasing. And the issue I've spoken about, whether the backlogs are going to affect the tests and further infections, and that should not be the case. The important thing is that we've always said that clinicians need to be able to manage their patients regardless of whether there are results there or not, and we will continue to stress that. The issue around the 67 mobiles, they're distributed throughout the country in every province. We've provided the stats as to where they're distributed, and it's not all of the mobiles have been equipped with the machines, because the other half of the mobiles is used for sampling and screening, and it's been very, very effective because you need to have a private place, and we'll try and get the information. It's the Department of Health who decides where the mobiles go, but they've been very effective. Okay, so thank you. I think I've fairly covered it.
Yeah. Can we give Professor book your a slot for 2 minutes. So long, Dr. Chetty. I'll be giving your details to the portfolio committee members. They want to make a follow-up. I'll give them your number. Okay. Professor Boo? Professor Boo, we cannot hear you.
My apologies. Just to say that the board of the NHLS has been following this since the beginning of the year. We've been tracking how we've scaled up and how we've managed the situation, and the board is very pleased with the way the executive team have responded. The big challenge for us, as you know, is to be able to get the test kits. And we started ordering them very early in the epidemic, early in the year, and we have been expecting many more kits than the suppliers have been able to provide. So it was not a slow start on our part to order the machines, to order the test kits, and we continue with the support of the Minister of Health to try and expedite getting in the number of tests the country needs. But the challenges are complex and global, and so we continue to work in that regard. I think that from our part, I just want to clarify when Dr. Chetty says we don't charge for the kits. As you know, the way the NHLS works for the test, the way the NHLS works is that the provinces order the tests. We bill the provinces according to a price schedule approved by the Minister of Health, and that's how it's funded. So individual patients, unless they are private patients, would not get billed by us. We would bill their hospital or their clinic for the tests that have been done. At this point, we have not billed anyone for any of the COVID tests. We have not billed the provinces at all, but we cannot continue to fund this from within the NHLS. Because we've improved our financial situation and we've reported to the portfolio committee on our progress over the last 3.5 years, we were in a financial position to make the investments required by the country to scale up our equipment, our test kits, our personal protective equipment, and all the other requirements from the resources that we had within the NHLS. But within the volumes of tests we are doing, we are going to need to charge and recoup some of the money that we have laid out. And then just finally to indicate that the board has extended its appreciation to the executive team and to the staff for the exceptional effort that has been made by the NHLS executive and staff throughout this COVID epidemic. Staff are working extremely long hours. I usually talk to Dr. Chetty by about 7 o'clock in the morning on her way to the NHLS, and I often talk to her late at night, well after dinner time on her way home. So I think, I just wanted to appreciate that effort. Thank you.
Thank you very much, Professor Buch, for actually leading from the front, accompanying the CEO, Dr. Kemi Chetty, who has given us a good presentation. We are grateful about this because as portfolio committee members, we get concerns over issues that are coming up. I think the members, I have given them your number, Dr. Chetty, in case they would want to make a follow-up on some of the issues that we have raised. But once more, thank you very much for your presentation. And you may stay if you so wish, but we are now switching over to another presentation. Thank you very much. You can then leave well if you do. Let me check if the leadership from Life Group of Hospitals
Thank you very much.
Thank you.
Honorable Chairperson, it's Ansuya Pediachi from the Life Healthcare Group, and the Life Healthcare team is linked in.
Right. Mrs. Padayachi, thank you very much for coming through. I have indicated that we would like to appreciate you for bringing the presentation to us early on time. We have been able to go through it, so we will only afford you 15 minutes to take you through the highlights, not the whole point by point, so that you can allow members to ask already the presentation that they have read. Honorable members, please start sending your desires, including Umamhlengwa, on my cell phone. Write down if you want to speak, then I can note you so that after the 15-minute summary by Mrs. Padayachi and her team, you could then start.
Okay. Thank you, Chairperson, and good afternoon to honorable members as well. My name is Ansuya Pediatri, and I'm the Manager of Community and External Affairs for the Life Healthcare Group. We'd like to thank you for the opportunity to address you today. Representing Life Healthcare in this meeting today is Adam Pyle, the CEO of Life Healthcare SA, Matthew Pryor, the Executive, Funder Relations and Strategy and Development, Dr. Trevor Frankish, who's the Life Healthcare COVID-19 Clinical Representative, Andre Joseph, the General Manager, Funder Relations. Honorable members, in the interest of time, and as the chairperson has just indicated, our presentation has been condensed to allow for more time for discussion. Through you, Honorable Chair, I now hand over to Adam Pyle to start off our presentation. Thank you, Adam.
Thank you, Ansuya. To the Honorable Chair and members of the Honourable members of the Parliamentary Health Portfolio Committee, thank you very much for the time this afternoon, and thank you for affording us the opportunity to interact with you. Andre, do you have the presentation up? Was it?
Adam, can you see it?
I can't see it. Can anybody else see it? While Andre gets it up, there's a few introductory, just a few points. We only have 15 minutes, so Andre, what I'd like to do is, there were a few slides up front covering who Life Healthcare is. I think what we should really do is bypass those slides. They're just really covering our facilities in Southern Africa, our operations in Europe, and also what type of facilities we have here in Southern Africa. I think what we should rather do is move forward into how we are tracking and dealing with the COVID-19 pandemic. I think that'll be far more use, and we can cover that in 15 minutes, then take questions after that. So I think, Andre, it'd be much better use of our time if we just bypass the first few slides and then move on to Matthew's slides, which sort of cover the Matthew, then Trevor, then yourself in terms of how we're handling the pandemic.
Adam, I'm unable to get that presentation up. I'm sorry. Trevor, can I ask you to maybe try?
The presentation was already up when Mr. Padayachi spoke. We saw it when Mrs. Padayachi was speaking through. So what has happened to it now?
Oh, there we go. It's back up.
Is it visible now?
Yes, it is back up, Trevor. So, Trevor, do you want to just jump to slide 5? I think that's the keep going down, keep going down, keep going, and we'll hand over to Matthew at this point here. Thank you very much.
Thanks, Honourable Chair and Honourable Members. I think our response to this pandemic really revolves around 3 particular pillars. First of all, looking after the community in terms of patients and visitors. Our employees and our hospitals are an important pillar along where we are trying to ensure that we have adequate response. And then, of course, enormously is our engagement with government to ensure that we collaborate on the management of the pandemic, report data, to be able to guide the national response, and of course also to make bed availability available to treat state patients where such capacity is available. Can you put on the next slide, please? So I think our response has effectively and collectively to engage with various parties in order to ensure that the industry responds as effectively. We are engaging through both the Hospital Association of South Africa as well as Business for South Africa through the new B4SA. We, of course, are also engaging with all spheres of government, We have given presentations to the KZN, the Eastern Cape, and the Gauteng Health Portfolio Committees. We are engaged in the provincial COVID task teams at Gauteng and Western Cape, and of course engaging with national. We obviously want to assure that the safety of our staff and preserve their jobs, except of course that we are going to get things wrong sometimes, to reflect and share learnings and best operating practice, and of course, have some agility in our ability to respond to the pandemic. I think I just wanted to give you a feel of some of the emerging challenges that are coming from the pandemic. I think healthcare availability is certainly becoming a major concern. There's a isolation and quarantining policy which is essential, but nonetheless that does reduce the capacity of staff available for ourselves. There's normal sick leave, of course, for people who might actually have contract the disease. We have to shield vulnerable staff, particularly those with comorbidities or are aged. And then, of course, we also are facing some reduction in staff due to them accepting 12-month state appointments. This is causing particularly shortages in the Eastern Cape and the Western Cape at the moment. Procurement of PPE continues to be a challenge. Recent removal of the ITAC credit is problematic. We are trying to support local manufacturing wherever possible, but some of the PPE does have to be imported, and we are making a plea through to the applicable ministry to ensure that that ITAC rebate on the duties does get reinstated. Community transmission is definitely a challenge. We obviously need to ensure compliance with guidelines and protocols. Given the number of guidelines and protocols that are out there, this is proving to be extremely difficult, as well as given the lack of detail in some of those guidelines. We need to retain some ability to cater for non-COVID patients. This is also proving to be a challenge. Ongoing emergency and necessary care does need to continue alongside the COVID treatment. Labour union involvement continues to be a challenge. It does require that we often have to engage and provide information, and we have had some challenges with some of the unions at some of our facilities. We need to ensure that there's an adequate supply of oxygen, and we are involved in a task force to ensure that the oxygen supply is adequate. We think that there is a bit of a shortage and availability challenges around high-flow oxygen supply, and then some inaccurate media reports certainly not helping the situation. If I can go on to the next slide, which really talks to the bed capacity negotiation that we've been engaging with at the national level. We obviously are wanting to help support the pandemic, and we think that really we've got to the point now with national where we have an agreement. The contracting will happen separately between ourselves and the doctors and other professionals, and there will be a role for an administrator to play to ensure that claims are paid on time and accurately to the various providers. The referral will happen on a doctor-to-doctor basis. We're calling it a JOC that will exist in the public system, a JOC that will exist in the private system, and that the referral will really involve the handover of a patient at the individual level. And the basis of the tariff that has been proposed, although we haven't had official confirmation from the NDOH down to the provinces yet, is based really primarily for critical care beds with a split of 55% high care beds and 45% ICU beds. There's also a care beds and a rate for palliative care. The critical care rate that has been proposed is 16,156 Rand. This includes VAT. It includes obviously the nurse, the bed, and all the stock that is used. Now, we have shared some data with the Department of Health around the utilization of stock. This is a pure cost to life healthcare. We don't make any margin whatsoever on the utilization of stock in our hospitals, and we are absolutely, we remain, concerned that this is not really on a cost recovery basis. It is below that, and we would face sustainability challenges for our organisation should this rate persist for any extended period of time. With that, I think I'd like to hand over to Trevor, who will speak a little bit about healthcare worker and safety. Thank you, Honourable Chair.
Thank you very much, Honourable Chair and Honourable Members. So just to emphasise that the mental and physical health of our staff is vital. I just want to check, is the video working properly? Okay. Well, very often the issue about PPE is in the headlines. We do provide that within the NICD guidelines and various other professional societies and international guidance. But it's very important that PPE is only one part of infection prevention. The others include the hand washing, the social distancing, etc. We do make sure that our employees are trained in the use of PPE, including how to put it on and take it off properly. We're very aware that very often when infection is transmitted, when they're taking PPE off after dealing with patients. So we manage the persons under investigations and COVID positive patients according to the guidelines. Clearly, disinfection of surfaces and environment is important and is ongoing, and special measures are taken. With our vulnerable employees, we are trying to avoid them being in the front line and therefore exposing themselves, and we rotate our shifts to minimize the emotional and physical burden. And also to protect staff, we've offered influenza vaccinations to employees and the doctors. Just trying to move it on. I may have to unshare and then share again. If our staff do become exposed to COVID positive persons, we assess them individually. How high is the risk? The NICD has provided very valuable guidelines on how to manage it. I won't go into the details. That's available on the site. In terms of quarantine and isolation facilities, we do have facilities within our hospitals or in other facilities such as bed and breakfasts or hotels where we've obtained accommodation for them. Our employees and their families also have access to our in-house employee wellness program, which is delivered by Life Employee Health Solutions. And we are very aware of the trauma psychological trauma and anxiety that staff are going through, both when they've been diagnosed as positive and also when they are in isolation. And we have an assistance fund to our employees. We have a particular program with the Gauteng provincial government, which I won't go into detail now, but this is just some of the information that we share with employees in Gauteng. In terms of our healthcare workers exposure, we have something like 16,500 employees. We report any exposure or COVID positive cases to the various departments of health. And today, just under 2% of our staff have actually been, staff and doctors, because they are not employed by us, have been diagnosed as positive. So there's the breakdown by province there, but also in the interest of time, I won't go into that. That's in the presentation. You will see certainly in the Eastern Cape, Western Cape, the high numbers there. Just in terms of Life Esidimeni, we have a number of facilities, particularly frail care and chronic mental health facilities, just shown there. Again, if we look at the situation in the Eastern Cape, we are talking mentally challenged people and frail people, where it is very difficult for them to comply with the norms required of social distancing, hand washing, and so on. So it is a particular challenge in those type of facilities. And then I'll hand over to Andre Joseph to continue with the risk reduction.
Yeah, thank you, Trevor. Can we go to the next slide, please? Yeah, thanks, honourable members, for the opportunity. Reducing the risk in our facilities is obviously important. We want to keep the virus outside. To do this, all visitors and the patients are screened on arrival at our facilities, And if some of them are found to be symptomatic, they are directed to a designated area, usually in our A&E department, to be properly assessed. And if necessary, then they are treated as persons under investigations. Our employees and our service providers are monitored on a daily basis for early symptoms. So as they arrive for the shift, they go through a medical surveillance. And if they do have symptoms, they are sent home. We are now trying to get them to do the symptom checking before they come to work and then stay at home. In the same way, doctors working in our hospitals are also monitored for symptoms. Universal masking has been introduced about 4 or 5 weeks ago to reduce transmission from asymptomatic or pre-symptomatic carriers. So you'll see that within the hospitals, all the staff, the visitors, patients are masked. And then very important, as Trevor also alluded to, health education on standard precautions against infections for employees, visitors and patients. And Life Healthcare has made cloth mask and hand sanitizer available for all its staff for use to and from home. So the hospital proper is important, but the adjacent facilities are also a focus. So therefore, the consulting rooms, radiology and the path labs, in these areas, we limit the number of patients waiting, and we advise our doctors to use telephonic consultations as far as possible. As before you enter the hospital, there are temporary facilities that have been erected to screen visitors outside of the hospital. As the winter months approach, it's becoming more and more difficult to keep that outside, and we moved it to just directly inside of the hospital. In the admissions area, you will be aware that if you are admitted early in the morning or midday, there's usually a lot of people in our admissions area. We got around that by actually staggering the admissions time, and the social distancing is enforced. Wards and high care, we have some actions there to ensure that the virus is not transmitted. And in theatre, theatre is our least risky area because, sterile practices are already in place in that area, but there are still, especially in the staff canteen and change rooms, we do enforce the social distancing. Next slide, please, Trevor. Just want to talk a little bit about disaster planning and surge planning. All our hospitals in Life Healthcare have surge plans in place. These have been verified by independent persons that are separate from the local management. We wanted somebody to go around to do the verification orders to see that things are in place. Then outside of the local hospital, there's a regional plan to assist if any individual hospital should run into trouble. At the moment, the private hospital industry is working on a bed availability application. As the numbers increase, we're going to have to know at a moment's notice where a bed is available in public and in private sector, and we hope that this application will help with that. We do have virtual meetings thrice a week to gauge the situation on the ground, and this is where local managers really share all the best operating practices. We still have to make provision for non-COVID cases that are medically necessary, as Matthew alluded to. Resource capacity. Next slide, please, Trevor. A very important aspect of our response to COVID is the establishment of doctor COVID committees. These have been established at every hospital, and they really assist and guide the hospital with the disaster and the surge plans. They do plan for the availability of doctors. As doctors become infected and have to isolate or quarantine, we have to have a supply of doctors coming through. They consider and agree the clinical guidelines using the NICD guidelines as the base, and they advise on clinical management where the NICD guideline is silent. So where the NICD doesn't address a certain matter, we refer these to the doctor COVID committees. They are also charged with the education of other doctors and on the clinical protocols. Not important now, but we do think it will become important later, is a subcommittee that deals with ethical issues around utilizing non-treating clinicians. And this is really will become important where we have to decide who is treated and who is not treated. We've also then engaged with professional associations of specialists for guidance on clinical management. Next slide, please. This slide really just talks to and summarizes.
Hello. I'll ask you to condense your presentation so that you allow members to ask you questions. Now, these are the questions, these are the slides we would have wanted to have earlier on. and now your time is running out to present.
Okay. So these are the just a summary of per province. We've put adult beds, adult high care, adult ICU. This excludes the neonatal and pediatric and oncology and maternity beds because we still have to preserve those. So we only showed you the adult beds as well as the ventilators and the anesthetic machines. Next slide, Trevor. Reporting is available really so that we can guide our response. And this is just to show what has happened just in life healthcare and how the numbers have increased in line with the epidemic that we've seen in the country as a whole. Currently admitted, you can see Eastern Cape and Western Cape again as in the rest of the industry, both public and private. Eastern Cape and Western Cape has the most patients admitted. Currently, we have 301 patients in our hospitals, of which 154 is in the Eastern Cape and 65 in the Western Cape. Deaths, 63 in the Eastern Cape and 16 in the Western Cape. We have 93 deaths since the 22nd of March when we admitted our first patient. Next slide, please. Life Healthcare reports into the NICD and every day, so we report by 11 o'clock in the morning. NICD reports into the provincial and the national ministers by 2 in the afternoon. And so we'd want to recommend that the NICD reporting route remains that because we think the data gets cleaned and all duplicates are removed and there's one repository of data. Thank you.
Thank you, Andre.
Honorable members, thank you for that presentation. We would like to request that you ask questions in the following order. Take your numbers down. Number 1, Honorable Kenny Jacobs. Number 2, Sokacha. 3, Honorable Chirwa. Number 4, Honorable Janchi. Number 5, Honorable Imam Sheikh. Number 6, Honorable Kwahube. 7, Honorable Malika. Number 8, Honorable Baha. Number 9, Honorable Christians. And number 10, Honorable Ismail. I haven't been able to ask questions. Let me start. Last week we were doing oversight in the Eastern Cape, and we actually were shunned by one of your CEOs at Umtata Life Care Hospital. I did receive an apology from Mrs. Padayachi, but she didn't explain. Of course, she was not able to. She couldn't explain why that CEO behaved the way he did. I would like to actually get that, even if it is written to me separately, but that was actually an unbecoming behavior when we were doing an oversight in one of your facilities, and he's actually not available or willing to share with us this information that we now have in front of us. Honorable Jacobs. If Honorable Jacobs has a challenge, let's get to Honorable Sokacha.
Thank you very much, Chairperson. Let me welcome the presentation. Just 2 questions, Chair. The first one is around the service level agreement that the healthcare is having with government. I just want to check, Chair, that they have with government in terms of their relationship with provinces. Is there any cost involved in terms of that service level agreement with provinces? Then the second one, Chair, is around the quarantine facilities. I just want to check if an employee has been found to be positive. I'm sure, as the presenter have indicated, they've got quarantine sites. What happened in the case when a family member of the employee is also found to be positive? Are those family members welcome to be accepted to those quarantine sites of the healthcare? Then the last one, Chair, it's around...
No, that's No, Honorable Sokacha.
Thank you very much, Chair.
Yeah.
Thank you, Chair. Thank you.
Honorable Sokacha, your video was off. Now I can see Honorable Chirwa, her video is on, and now she can speak. Please, let's switch our videos on when we speak, okay?
Thank you, Chair.
Honorable Chirwa, it's your chance now.
Yes, thank you, Chairperson. I had asked to ask questions for Netcare, so I don't know if I should go ahead and ask LifeCare for questions that are meant for Netcare.
Oh, sorry. Okay, then let me skip you. I was not aware. I just saw your name. Okay. Honorable Janji.
Thank you, Chairperson. Thank you for raising the disappointment that we encountered in St. Mary's Hospital. And I hope you will share with us the report that you will get on why, when we had written a letter to the invited the person to the meeting, and the numbers that the life is recording of the infected and of deaths, particularly in the frail care. Can the presenters tell us whether these deaths are really COVID deaths or are deaths within the facility? And the second question, Chairperson, is what percentage of let me not say nurses, let me say percentage of healthcare workers that are infected are working both in private and in the public, moonlighting? Because the one of the negative media reports is that most of the nurses that get infected in the public are the nurses that are moonlighting. Are they aware of that? Thank you very much.
Honorable Imam Sheikh.
Thank you very much, Chair. Yes, indeed. Thank you very much for that presentation. Now, I have a very critical question, and I think you attempted to talk about it, but then you didn't complete it. Could you perhaps tell me and tell us whether you've been in any discussion with provincial departments of health and or national, where you've discussed the issue of criteria? What criteria you are going to be using to either accept or reject patients that are wanting to be admitted in your facilities? That's the first thing. And if you do not have such a thing, I'd like you to tell us how you're going to actually implement that in any event. And then you say that there's a shortage of PPEs. I'd like you to explain to us exactly what, because my understanding is a great percentage of those PPEs are locally manufactured, and we should be taking advantage of that. Thank you.
Honorable Kwahube.
Thank you, Chairperson. Mine is two questions, very brief. The one relates to a slide. I can't now remember which slide it was, but I'm sure the team will remember, where there was a breakdown of deaths in hospitals per province. I note that despite the Eastern Cape being now the second most, having the second most cases in the country after the Western Cape, they have about 63 deaths in your facilities. And I want to understand why. My understanding would be the province with the most amount of cases would in fact have the most amount of deaths. But that does not seem to be the case in this scenario. And then the other question, my last question is, we're aware that obviously, discussions are being had between the private healthcare sector and particularly the private hospital groups with government regarding ICU beds and utilizing those beds and high care beds. Now, what I would like to find out is at what cost are these beds being going to be contracted to government? So, if your group is going to be giving government access to some of your ICU beds as we head towards the peak, at what cost are we looking at, and what are the considerations on your side? Thank you very much, Chairperson.
Honorable Maliga.
Thank you, Chairperson. My question is, I want to check how is the Life Healthcare Group collaborating with other private healthcare providers to tackle COVID-19? And due to the large number of health professionals that has tested positive for COVID-19, can they please provide us how many tested positive and how many recovered for the Life Healthcare Group? Thank you, Chairperson.
Honorable Bacha.
Thank you, Chairperson. Chair, let me also welcome the presentation. Chair, two quick questions on my part. One, Chair, has to do with the challenges posed by life asset many establishments, specifically with mental cases that they have. What is the strategy that is employed in ensuring that they keep to the protocols as promulgated in fighting COVID-19? The second one, Chairperson, is the peak of COVID-19 is projected to be around August, September. What is the level of readiness of life healthcare in terms of keeping up with the projected peak when it does arise? Thank you, Chair.
Honorable Christians.
Thank you, Chairperson. My question is, what is the agreement, or is there an agreement between the private health sector, in other words, Life Healthcare Group, and the government during COVID-19 outbreak in respect of health services provided? And are there any compensation arrangements between the private health sector and government? Have you agreed in respect of the ICU beds, which has already been questioned, on a tariff rate, or are the discussions still ongoing? And then I would just like to voice my appreciation for Life Healthcare Group and the mental health and well-being that they are providing to their staff members. I think that's really great. And then lastly, just a very straightforward question that another colleague has also touched on a little bit, is that we are going to be peaking in the next few weeks. In fact, they've stated that the peak might reach around 40,000 deaths. I would like to know if Life Healthcare Group is geared up for this peak in the coming months. Thank you, Chairperson.
Okay. Leadership from Life Group, you have all the questions now. Please distribute them amongst yourself and just start firing, because we'll have to stop the meeting exactly at 5 to allow for another presentation to the members. Thank you. You can now start.
Thank you very much, Honourable Chair. This is Adam Powell. Let me just start off with, we'll distribute the questions. I would like to start off with the visit to Life St. Mary's Hospital in Mthatha. And I did phone and apologise, and certainly from a Life Healthcare perspective, we were really disappointed as to what happened. It was really not our intention to waste your time, and certainly not our intention to show you any disrespect. We would have welcomed the opportunity to show you around Life St. Mary's. We had our nurse manager test positive on the Saturday afternoon, and our hospital manager he went into quarantine on Sunday and subsequently been tested positive. We will certainly be doing our investigation in terms of exactly what transpired when he gets back from his isolation. And we will certainly be giving a report through to you and your portfolio committee in terms of the life testimony and what actually happened on that particular on that Monday. So just once again, an apology from a Life Healthcare from that perspective, from what happened. And from our side, we certainly did miss an opportunity to show what was happening at Life St. Mary's. What we are going to do is I'm going to hand you through to the questions, and I think Matthew, why don't we start with you, and you can deal with the questions regarding the agreements between public and private, and then we can hand over to Trevor from there, and we'll split the questions up that way. Just make sure, Matthew, just go through the questions you're dealing with and the members who asked them.
Thank you, Adam, and thank you, Honourable Chair. I think as a theme, I think there seems to be many questions around contracting for private hospital beds by government. So I think honourable members, you might recollect that during the issuing of the regulations of the Disaster Management Act and the regulations surrounding that, there was a specific non-exemption given for the private hospital industry to discuss pricing as an industry. We had to be given specific dispensation by either the Minister of Finance or the Minister of Health in order to discuss pricing as an industry. We were given dispensation to discuss other issues, coordination of capacity, and planning, and ensuring that we were able to report data through to the national department as well as the NICD, those kind of things. But we came off from those regulations with a specific dispensation that we were not allowed to discuss price as an industry. And so we commenced really through two processes, both through the Hospital Association of South Africa as well as through B4SA, where we set up a working group of all the facilities or all the private facilities across the country. So that's not only the Hospital Association of South Africa, but that's also other facilities that are not particularly that are not represented through the Hospital Association. The process from there on was really guided through an engagement where the Department of Health at the national level requested a bilateral process to be undertaken. And so we got letters, ourselves, Life Healthcare, got a letter requesting a proposal. We submitted that proposal through to the National Department of Health. We followed up on that proposal, and then I think it was last Tuesday, this culminated really in a briefing that was held by the Honourable Minister of Health to the private hospital facilities as well as the doctors on the pricing that they were going to recommend to the provinces as the maximum pricing. Now, those specific prices are in the presentation. So for the hospital services, it is a blended rate across ICU and high care, and it's a daily rate. And if memory serves me correctly, it's about 16,500 Rand. That 16,500 Rand, you've got to bear in mind, the first thing you've got to do is you've got to take VAT off. Life Healthcare is registered as a VAT vendor. We have to pay 15% of whatever we receive in VAT inclusive rates through to Treasury. So you take that number off as a start, and then if you take off the stock that is used on those on these patients that are in ICU and high care, we would suggest that the rate is significantly below any level of cost, significantly below our cost recovery level, and is not a sustainable rate. It's healthcare pricing is obviously is always an incredibly complicated undertaking, but I can assure the honourable members that our financial statements are in the public domain. Our profitability levels are also in the public domain. We have just been through an entire process with the healthcare market inquiry, where to summarize really their findings was that there was no excessive profitability within the private hospital market. And so if it was going to be on a cost recovery basis, which let's remember even at that level would not be sustainable, the pricing we would suggest would be higher than the existing pricing that has been put on the table. Nonetheless, in the interest certainly of meeting the challenges of the country, hi Richard, we're just starting to discuss pricing. Perhaps I could ask that you come on in about 15 minutes. My apologies.
Of course, yes.
We are committed to ensuring that we meet those challenges and to and have agreed to participate at those pricing levels. So then the next step of the process is to establish a service level agreement and a memorandum of understanding. We're in advanced stages of establishing that with 2 of the provinces, and our view is that we will be using that SLA as the basis of engagement with the balance of the provinces. Just trying to remember if there are other issues that the crisis of patients coming into our hospitals. Our understanding is that this will be a referral process from the public sector, where they will decide which patients should come across to the private sector, and that there will be a managed care process applied in that referral process by the Provincial Department of Health before they send us those patients. I think that's about it from me. Adam, perhaps we could hand over to Trevor to talk about Isidameni.
Yes, thank you.
Thank you very much, honourable members. In terms of just going through the various questions, there was a question about the quarantine facility. If a member is positive, if their family would be allowed to attend. We haven't had such a request yet, but the staff are really quarantined or isolated to prevent further infection towards their family. So it is trying to limit any further contact, but if we had such a request, we would consider it. In terms of the numbers in the Eastern Cape, we are really concerned about what's happening. We think that it's a reflection of the burden of comorbid disease, but the information that the NICD is gathering is very informative in terms of what are the comorbidities, and we can get that information from them. It is also publicly available on their site. The questions are about deaths in the frail care centres. There have been some, and we do have to remember that almost all of those patients have a number of comorbidities, but they have been, most of them have been COVID related. We asked a question about recovery, and I think in general, both in the acute care and in the Isidameni facilities, what we are seeing is the pattern in the rest of the country. About half of the people so far have recovered, because the others are still active cases, but they are recovering. In terms of the questions about the deaths by province, as I mentioned, that needs to be investigated further as we understand the comorbidities. In terms of keeping to protocols, we make that very strict towards our staff. We do have to remember that there's many asymptomatic people, anything between 30 and 40%, where we don't pick up that somebody may be infected at the time. And so the infection can be brought into our facilities despite our best measures. I think that covers the questions that I had.
Thank you, Trevor. I think there was a question from Honourable Member Iman about Trevor. I'll cover about the PPE. Do you want to just talk about after that the criteria for accepting or rejecting patients? But just a question about PPE. So we have certainly tried to source locally, and particularly on items like gowns. There are a couple of suppliers. We've asked them to double up their capacity in producing gowns. In fact, if they could treble or quadruple their capacity, we would take it all. And we are engaging with certainly other suppliers in terms of the manufacture of gowns. And if there are, for us to be able to utilize this opportunity to get local production PPE is something we would certainly chase and certainly help in terms of improving employment, etc. So that is something we're certainly looking at. Unfortunately, a lot of the PPE does come from areas like China, and we have to manage it, but we'd much rather purchase locally where we can. That is something we are looking at quite aggressively. And then there were some questions from Christians and Bacha that regarding the peak of COVID, are we ready? I think that is, we have surge plans in every single hospital. Dealing with this COVID pandemic is really difficult. It's the biggest challenge I think we'll have is staff capacity and bed capacity, and it comes in waves. For example, in East London, over a week ago, we jumped from 70 cases to 100 overnight, and we expected then to wave to start coming the next day. 1 week later, we actually have 92 cases, so we actually have 7 or 8 cases less than what we had. So it is really difficult to plan. It is really difficult to manage. We have surge plans. So in East London, we could add another probably 100 patients into St. Dominic's and into Beacon Bay. We have plans in terms of our day facility, St. James, which has another 38 beds. We're trying to leave the East London hospital, private hospital, aside because it has a lot of renal dialysis patients, and we really don't want them exposed. Bless you. And we have, so my guess is we could probably take another 200 patients in East London at a real push. So we have to, it's really difficult. We have surge plans for hospital, and what we are doing is we'll start moving staff across provinces. So we have brought staff in from Gauteng, from KwaZulu-Natal, into the Eastern and Western Cape to help. And maybe one of the good things if the surge happens by province is then allows us at some point to take our staff from the Eastern and Western Capes back up into inland and KwaZulu-Natal if and when the surge, the pandemic hits there. I think that's in terms of the peak. Because anything from the criteria, Trevor, you want to deal with?
Yeah, sure. Yes, I think the criteria for admission are basically from the NICD. Those patients who are ill, and it does depend on their temperatures, their pulse, their symptoms, and also their oxygen saturation. That would influence whether they're admitted. We are trying to send patients with mild illness home as much as possible, simply because we don't have the capacity to admit unnecessarily. And then there was another important question which I hadn't addressed, and that was the question of moonlighting. We are very conscious of moonlighting and the fact that people move between hospitals, and we have absolutely restricted nursing movement between hospitals, and also try to ask our doctors not to move between hospitals. And in terms of agency and so on, we've tried to restrict the use of people who are not our own staff, just to eliminate that problem. Thanks.
Yeah, we still have just 1 minute. May I request Honorable Ndongeni to come in, because she comes from the Eastern Cape. I didn't see her. She might as well wanted to ask a question there. I'm going to take just that. Only one question, Honorable Ndongeni. But Trevor, the issue is not an issue about nurses only, even doctors. At Umtata, doctors are moving in from life care. They're moving into Umtata General Hospital. They move into Umtata Private. So that also is an issue. Okay. But can I get Honorable Ndongeni if she's still there?
Chair? No, Chair, I'm covered.
Okay. Okay.
Thank you.
Thank you very much. We thank you, team from the Life Group, for your presentation. I was listening to the news today. The Premier of Eastern Cape, Honorable Mabuya Kulu, was also raising issues about Life Hospital in and around East London. Please follow up that matter. And he also was raising similar things that we raised about Life Umtata. Please make sure, because we don't only need you to do well as a Life Group, but we also need to get your support and your readiness for COVID-19 and beyond. Thank you very much. Then you are released.
Thank you very much. Thank you.
Thanks a lot. Bye-bye.
Thank you.
Thank you, Chair.
Bye-bye.
Chairperson, you are on mute.
Sorry. Oh, thank you very much. I wanted to say we are going to be listening to a presentation from Netcare now. There are members that I would like to prioritize to ask questions after the presentation. These are the following: Honorable Chirwa, followed by Honorable Wilson, Honorable Sheikh Imam, number 3, Honorable Ismail, Honorable Gela, Honorable Shlengwa, in that order. If there are any other members, we can maybe only take another 4 hands after this, but those ones must write to me and decline if they are not going to be asking questions. The 6 that I've mentioned, we will prioritize them after the presentation. I do notice that there's a gentleman with glasses there who is from Netcare, and I would imagine he's part of the team that is going to be making presentations. Dr. Mhlongo, I have made a request to Dr. Friedland that we have already seen your presentation. We would like you to summarize it so that you allow members to interact with you in terms of questions. Please don't do slide by slide, line by line. We already have got the presentation. Go into the highlights in terms of your readiness and your readiness for COVID and even beyond, and the challenges that you have. I will also pose one question to you when we start. Thank you very much. Dr. Mhlongo, who will start?
Good afternoon, Honorable Chair. My colleagues, Dr. Friedland and Melanie Da Costa, are at our head office. Dr. Friedland will start with the presentation. I'll just check if he should be connected. I'll just check with him. Please give me a moment, Honorable Chair.
Yeah, sorry, thanks. Because the media is connected here, I must actually correct myself. They said I said Premier Ma. It's Premier Mabuyane, not Mabuya Kulum. Sorry for that. Yes, I can see someone ready to start. We can hear you, sir. We can see you.
Dr.
Good afternoon. Can you hear us?
Good afternoon.
Yes, we can hear you well. Good afternoon.
Good afternoon, Dr. Dlomo.
Good afternoon, Dr. Friedland. Go on. We can hear you well.
Good afternoon.
We can hear you, Dr. Friedland. Good afternoon.
We can't hear. And then you go call Travis quickly.
I'm going to log in myself, if you don't mind.
Dr. Dlomo, we're having slight problems. We're just trying to sort this out.
We can hear you well this side.
Dr. Dlomo, can you hear me? Dr. Dlomo, can you hear me?
Yes, sir. I can hear you well.
Apologies, we're just struggling to hear you, and I don't know what the problem is. If you give me 1 second, please. I could hear them initially, but
do you want to plug the jabber in here then?
I'm struggling, Travis, quickly, please. I can't hear them. Good afternoon, can you hear me?
Yes, we
Good
can.
afternoon.
We can.
We can hear you.
And then we can see you on the screen here. Good afternoon, everybody.
Good afternoon, everybody.
Which one do you want? Which one? This one?
Yeah.
Dr. Friedland. Mr. Mshongo.
Yes, ma'am.
Can Mr. Friedland continue? Dr. Friedland, can he continue? The chairperson has got a problem.
Honorable
yes, I
Judge.
can continue.
Yeah.
I can continue.
Yes, continue, sir.
Thank you so much. Good afternoon, honourable members, and thank you for this opportunity of presenting to the Health Portfolio Committee. I'm wondering, ma'am, if everyone, honourable Member of Parliament, whether everyone can hear me.
We can hear you well.
Thank you so much. So thank you very, very much for this opportunity to present to the Health Portfolio Committee. And at the outset, may I recognize the stewardship of Dr. Dlomo and of this committee during these very trying and challenging period in our country's history. May we also at the outset applaud the decisive stewardship of our Minister of Health, Dr. Mkhize, as well as the National Department of Health in tackling this pandemic. And as we've made clear, that Netcare stands ready to play its part in working with government and the National Department of Health in fighting this pandemic. And as you would be aware, honourable members, in March of this year, we declared publicly we would stand ready to assist government and the public sector in treating state patients on a cost recovery basis. In other words, a not-for-profit basis. And we want to do that and reiterate that our pledge is to treat all of our patients, irrespective of where they come from, with absolute dignity, compassion, and the outstanding care that they deserve.
Can we please get to the presentation? Thank you.
Thank you. Thank you, Dr. Dlomo. I can see you. Can we put the presentation on the screen, please? And can you give me presentation rights, if possible? I've gone on to the presentation. Can you hear me?
Yes, we can hear you.
And can you see the presentation on the screen?
Not yet.
And can you see the presentation on the screen?
Not yet. Not yet, Dr. Friedland. Can somebody flag the presentation?
If someone could put the presentation on the screen, I'd appreciate it. And I can point to, I was told by Dr. Dlorm to spend time mainly on our capacity.
I was told by Dr. Dlorm to spend time mainly on our capacity.
I'm sorry, we just got a speaker problem here. Take this jabber off, please, and let's try it without. Can you hear me now?
Yes, Dr. Friedland, we
Yes.
can hear you.
Is it possible for someone to put the presentation on the screen, please?
Dr. Friedland, who has got the presentation other than yourself?
Need some help here, please.
Dr. Friedland, who has got the presentation other than yourself?
Dr. Dlormo, can we put the presentation on the screen? Thank you. Thank you very much. Right, can they hear me?
Yes, go on. We can hear you. Just move on.
Thank you.
We text you, don't hear you.
Thank you very much. So, Dr. Dlormo, I'm going to skip through the initial slides given the time, and I'm going to go straight on to our capacity. So I would ask that we move as quickly as we can through to slide number 10, if at all possible. If we can go to slide number 10, the introduction, that's it, thank you. And if we move on to the next slide, thank you. This slide over here really demonstrates the capacity of critical care beds in South Africa. And what it demonstrates is there are a total of 6,040 ICU and high care beds in South Africa. The private sector has about 3,780 of these. And if you look at Netcare, we have about 1 in 3 of the critical care beds in the private sector and 1 in 5 in the country. And then if you look at the number of ventilators, we have about 1,048, and we can increase these to just over 1,400 if we include anesthetic beds. And what the graph shows you is our representation in the country. And you can see obviously in the Gauteng, we have a lot of representation, and then in KwaZulu-Natal and the Western Cape, and less so in the other provinces. If we can move to the next slide, please. And this is a demonstration, honourable members, of our number of hospitals throughout the country, predominantly in the Gauteng, Western Cape and KwaZulu, as well as 2 in the Eastern Cape and elsewhere. And if we move on to the next slide, please. This is a demonstration of our acute beds by province. And again, you can see our general wards versus high care and intensive care units. These are our adult beds. They exclude pediatric, rehab, psychiatry, and also maternity. And if we go to the next slide, please. And then in terms of dividing up and preparing for COVID, we've divided our hospitals into 3 zones: a red zone for COVID positive patients, a yellow zone for those patients under investigation, and green for those patients who are requiring help outside of COVID. And we, as you can see under point number 4, we've got a very phased approach to surge capacity, and we're able to flex the number of beds that we can provide for COVID patients. So if we go to the next slide, please. This shows you our risk stratification strategy. On the left-hand side is the total number of beds we've prepared for COVID, 1,024, plus 821 for patients under investigation. And the red are in the green, the rest are in the green zone, which means these are for patients that don't have COVID and are normal hospital patients. But depending on the surge and the requirements, we are able to flex this quite significantly. And if we go to the next slide, what you can see on the next slide is, in terms of high care and ICU, how we've risk stratified that in terms of the red high
Dr. Friedland seems to be frozen.
I thought I was the one who's frozen.
No, you don't. You're not frozen. He's frozen.
Yeah, Dr. Dromo, we've lost the sound completely.
Apologies, can you hear me now?
Dr. Friedland, please get going. We can hear and see you.
Apologies, I've had to change computers. Can you hear me?
We can, Doctor.
I am so sorry about these technical problems. I'm deeply embarrassed. Forgive me. Could we then move on to the next slide, please? This is the total number of ICU, number of ventilators we have in the country. And what we've realized is that it's not actually the number of ventilators that is important. It's actually the amount of oxygen outlets we're able to provide in our hospitals. And we've done a very significant, detailed analysis of the amount of other devices we can use to supply oxygen to COVID positive patients. Because as we've seen as clinicians and healthcare workers, there are other modalities of providing oxygen therapy that are probably more effective than ventilation alone. So whilst we could have 1,400 odd ventilators, we could use another 1,692 beds on top of this, where we can provide different forms of oxygen. So our capacity within Netcare is almost doubled in terms of high flow nasal ventilation and other modalities if we look at outside of a ventilatory support. So what I'm saying, Honourable Chair and members, is that our capacity of ventilators is approximately 1,048. If we add on our anesthetic machines, that takes us to about 1,400. But if we are able to add our oxygen capacity through other modalities, where we will be able to add 1,692 beds. So that should give us well over 3,000 beds that can provide further oxygen support through other means. If we go to the next slide, please. Could we go to the next slide, please? Can you hear me?
We can, Doctor.
Thank you so much. It would be slide number 18, please. Anyway, if you can't get there, slide number 18 will just tell you the number of admissions we've had to date of COVID positive patients. It's about 664. But as we speak in our hospitals, we have just under 400 COVID positive patients. Those numbers are rising. And we have another just over 300 PUI patients. And those patients, so it takes us to about 700 patients in total in our facilities. I wonder if you could go to the next slide. Just in terms of the commitment I made earlier, we have successfully reached contractual agreements with the Western Cape in terms of a service level agreement, and together with our Minister of Health in terms of a national tariff. And as we said right in the beginning, our objective was to do this at a cost recovery basis, and that is the basis on which we'll be contracting with the Department of Health in fighting this pandemic hand in hand. And if we can go to the last slide, if you don't mind. the one before that, as I said in my introduction, we stand ready, Honourable Chair and Honourable Members, to play our part in working with government to ensure that we fight this pandemic. And as we said in March, this is not about making profits. It's about putting aside personal interests, and we want to be able to do this on a cost recovery basis. And importantly, whether the patients are from the public or the private sector, Honourable Chair, we want to ensure that we treat them with dignity, compassion and outstanding care. I'll stop there, Honourable Chair. I know I've rushed through the capacity slides and happy to take questions or go back to some of the original slides if necessary. Again, apologies for the technical issues.
Right. There were quite a lot of technical issues. I hope that our members were still able to follow your presentation. I will now take I'm sorry, I must apologize firstly to Honorable Sukers, who has been completely forgotten by me in my list, and therefore she will really come up in the list. Can I get the following members to prepare themselves to interact with the presentation? Number 1, Honorable Chirwa. Number 2, Honorable Wilson. Number 3, Honorable Sheikh Imam. Number 4, Honorable Sukers. Number 5, Honorable Kwahube. Number 6, Honorable Kela. Number 7, Umam Shlengwa, if I didn't get her commenting. Number 8, Honorable Sokacha. And I would probably be the last one. And Honorable Ndongeni. Yes, Honorable Ndongeni, in that order. Honorable Christians, you had a share in the first 2 presentations. We may get you here if there is a slot, but some of these members they're getting the second bite. They haven't been asking in all 3 presentations. So let me then give them the chance in that order. Thank you. Honorable Chirwa, you start. Honorable Chirwa, you are number 1.
Can I proceed, please, Chair?
Proceed. Honorable Wilson will come back to her if she's able to log in. Honorable Wilson, start.
Thank you very much, Dr. Friedlander. I hope you can hear me.
Yes, I can, Honourable Member.
Thank you. And thank you for your presentation. It is greatly appreciated. I just have a couple of queries for you. And the one was a newspaper article with regards to the your Mill Park facility earlier this week, where there were complaints that COVID-19 positive people had been put into wards with people who were not COVID positive. It's obviously quite alarming. We do understand that some people may come in. Naledi, come with after I've finished. Sorry, doctor. So that was obviously quite concerning. We do know that people present often with asymptomatic who are asymptomatic, and it may take a day or 2 to pick up their symptoms. My question on that issue is, what have we done to try and stop this happening in the future? I know it's not an easy one, but I think it's a difficult issue. That's my first question. Yes. My second one, doctor, is with regards to your ventilations and your alternative use of oxygen on other types of equipment. At a total, it's still 3,000. We are seeing a massive escalation of COVID positive people every single day. Now, I understand that you are not the only hospital, and you're certainly not the only private hospital group. We've also had interactions with Lifecare today. However, having said that, the prediction is going to run into tens of thousands of positive cases shortly. Do you think, And in your opinion, do you think your 3,000 is enough? And in your opinion, with a combination of all the hospitals, do you think that we are sufficiently equipped in South Africa as far as ventilation and oxygen requirements are? Because we have heard that some hospitals have even run out of oxygen, that we are equipped to deal with this pandemic as it escalates. Thank you, Chair. Those are my questions.
Okay. Thank you. Can I?
No. You write them down, sir. You write them down. Honorable Chirwa. Honorable Chirwa. Still a challenge. Honorable Imam Sheikh.
Thank you very much, Chair. Thank you very much for the presentation. Netcare, you are a private healthcare service provider. Okay, we know that. We know that there's going to be an increased demand shortly for beds and ICU beds. How are you going to differentiate between patients coming from the public health sector and the private health sector for you to decide who you're going to accept or not? The other thing is there's a new innovation, I'm told, in terms of ventilators, where one ventilator can provide oxygen to 3, 4, or multiple patients at the same time. Is Netcare aware of that? Are you exploring that to see whether that could be one of the possibilities? And lastly, I'm concerned about your protection of your employees, not only whilst they are now employed, upon death as a result of COVID-19, are you providing additional benefits to their next of kin and things like that? Thank you.
Honorable Sukars. Honorable Sukars.
Yes, Chair. Can you hear me?
Yeah.
Okay, great. First of all, thank you for your presentation, and we do sympathize with your struggle with technology. I just want to ask the question, first of all, to commend your group for your contributions that you are making to the fight against COVID-19. My question really relates to what Sheikh Imam has alluded to, which is the outbreaks at Kingsway Hospital and St. Augustine, what the root causes were for those outbreaks at the hospital. There was mention that the personal protection equipment, the limited amount of that was mentioned in newspaper reports. If you could just give us an idea of what the root causes were and what has subsequently been put in place to address that. Then secondly, what we've heard from both the Department of Health and now with the Life Group as well, that with the capacity of the health system in South Africa, both private and public, being under severe strain in the coming weeks, what community interventions, such as auxiliary workers at a community level, would you recommend that should be brought or should be put in place? Contingency plans to upscale and assist with a surge in cases. Has there been a discussion within your group to empower at a community level those kind of interventions? Thank you, sir.
Dr. Friedland, please write your questions down because we are going to run through all of them one time. Let me read for you questions that are coming in from Honorable Chirwa, who's now experiencing some connectivity issue. One, give us an update on St. Augustine Hospital from the last challenge that you had. How do they plan to avoid a similar outbreak in their other facilities since they are now open to take public hospital patients? Number two, how will the tariffs of private doctors be treated when public hospital patients start utilizing their facilities? The last one, how often do they conduct, that is Netcare, how often do you conduct tests on your healthcare workers? Those were questions from Honorable Chirwa. Let me now go to Honorable Kwahube.
Thank you, Chairperson. A couple of questions from my side. We've heard about Sorry?
We will not take more than 3.
No, I won't be long. We've heard about the issue around the increased capacity that you've had to undertake during this time. Very simply, I'd like to know where did you start off in terms of your ICU capacity and your ventilators, and where are you now from your facilities across the country? By that, I'm trying to ascertain how have you grown your capacity over the past 3 months, and also where have you been attaining some of this equipment, because we know that there is obviously a global shortage. And so now we have a situation where private hospital groups and the government are both interrelated to some of the questions that have been asked. Disease control. We've seen that infection control in hospitals, particularly some of our private hospitals, has been a massive problem. And I think it's perhaps due to the increase in foot traffic and admissions. And so how are you dealing with that, particularly now that we've got backlogs with the NHLS? So how are you dealing with patients that are under investigation? How do you separate them and that kind of thing? Thank you, Chairperson.
Honorable Kela.
Thank you, Chairperson. Let me also welcome the report. Chairperson, it's very clear that the Netcare doesn't have challenges because they were not listed in their presentation. But Chairperson, I just want to check with them on the issue of PPEs. Where they procure the PPEs, are they also getting outside the country or not? That will be my question, Chairperson. The other question is regarding the critical
Honorable Kela, we've lost you. Okay, Mama Shengwa, come through.
Chair.
Yes, we got you cut off. What happened? Conclude.
Chair, I wanted to check with them regarding their critical care beds, whether, as we know that COVID-19 numbers will be increasing, and I just want to check with them, they have that capacity to procure more beds. Thank you, Chair.
Honorable Shengwa.
Thank you, Chairperson. Let me welcome the report, although it was some problem, but thank you for that. According to my understanding, Doctor, Netcare is doing very well throughout the country. But in terms of commitment, your commitment in preparation of the COVID-19, your commitment to the country, your commitment to the Department of Health. What are your role in the neighboring hospital, public hospital, who are struggling there, having, in terms of testing, in terms of ICU, in terms of everything, in order to uplift them and network with them, capacitate them, because you have a commitment with the department. Thank you.
Honorable Sokacha.
Thank you very much, Chairperson. Can you hear me? Chair?
Continue.
Thank you very much, Chair. Let me also welcome the presentation from Netcare. I've got two questions, Chair. My first question, I can see when the presenter was presenting, he was mentioning the high care units, the ICU units, and the acute beds per province. But I couldn't see the Northern Cape, so I don't know whether the Northern Cape doesn't have acute beds for patients. That is my first question. Then the second one, Chair, is around the recovery cost that Netcare is having with government. I just want to know what is the status. Can you just extensively explain the issue of the recovery cost between themselves and government? Thank you very much, sir.
The last two hands is Honorable Ndongeni and followed by Honorable Christians. That will be the last two hands.
Thank you, Chair. I just have only two questions. I don't know whether I'm audible.
Kubega.
Oh, ngiyabonga. A large number of health professionals have tested positive for COVID-19. Can Netcare please provide the figure for the live health care group? How many have been tested positive? How many have recovered?
Imagine ngeke baprovide life care.
Askisi. And Netcare, not life care. Netcare.
Okay, yeah.
Ngisahamba kahle.
Away.
All right. Askisi. Kuyafana. Okay, the second question is ndilahlekiwe ke ngoku.
I must return.
Masibesichitha ndilahlekiwe ngoku.
Honorable Christians.
Chairperson, thank you very much. I'm covered by previous members.
Yes. Dr. Friedland, those are the questions that Dr. Friedland, those are the questions that were asked by our members. Can you please assist us with the responses? Run through all of them one time. Thank you.
Thank you very much, Honourable Chair. And unfortunately, there were some questions we could hardly hear. And please interrupt me or correct me if I haven't heard all the questions. The first question from Honourable Wilson was about Mill Park. Yes, there was a complaint about a patient who claimed that she was in the green zone and was in the same ward as someone who had tested positive. Both patients, all patients that come into our hospital are pre-tested before they come into hospital for COVID. And we will only admit people into the green zone of the hospital if they are COVID negative. The difficulty is, of course, that as we know, if you are tested within the first 3 days, you may have a false negative. In other words, you have COVID, but you are asymptomatic and you don't present with symptoms. And we also know that only 75% of the tests record a positive. So there unfortunately are a number of false negatives. And this was the situation in the ward, but because we practice strict isolation and good PPE, no one was put at risk. But we would never ordinarily put anyone who we suspected of COVID or had COVID in a ward with patients who didn't. And anyone we suspect of having COVID, in other words, but didn't have a test result, say they came in as an emergency, would go into our PUI, our yellow unit, or persons under investigation. So I think that hopefully that answers it. But clearly there's a lot of anxiety out there amongst the public, and we need to respect that and assure them that we're doing everything in our power not to spread this virus whatsoever. The second issue was the issue of ventilators, and are there enough in the country? And I think that there was another question answered later about new innovations. And I think one of the advantages that we have in South Africa is that we've come into this pandemic later than some of the other countries. And as a result, we've been able to benefit from their learnings in terms of treatment. And I think in the early phases, our Chinese colleagues, Italians and French, were putting people on ventilators very quickly. And what we've now learned is that we don't need to put all people on ventilators. Yes, the desperately ill will require it, but there's certainly other forms of oxygen therapy, one of them being high-flow nasal oxygenation, that are as effective and have a better survival rate. And I think there's a big cohort of this being done. Something going on here. Can you hear me?
Yes.
We can hear you, Doctor.
Sorry. Thank you. And so there's a big study going on in Upscale Hospital at the moment of using high-flow nasal ventilation. And I think that when you look at the ventilator capacity in South Africa and you now add on the additional modalities that can be used, I think that will help us in the surge and capacity planning. Were it simply just reliant on ventilators, we certainly don't have enough in South Africa. But if you now combine ventilation with nasal cannulation and high-flow nasal cannulation, I think we start approximating far better numbers. The key issue that we all have to face throughout South Africa, and again, the National Department of Health is leading this study, is how much oxygen we have. That's the real rate limiting step for each hospital. In other words, we may have all of these modalities, but do we have enough oxygen in our hospitals? And I can tell you in Netcare, we've done an audit which tells us how much oxygen we have, and we have 11 of our 51 hospitals where we are urgently increasing our capacity, the size of our tanks, in order to ensure that we have enough oxygen to last. And we look at a minimum of 3 days of oxygen before we need to replenish. So this is a big issue in South Africa for each hospital to audit its oxygen supplies, because we feel that in the surge, we're going to have a lot of patients that are going to require oxygen, not just ventilation, but these other modalities, and it will depend on how much oxygen we have. I don't think any of us want to run out. And so I think this is the big issue. And so I think there was another question later. We've purchased an additional 100 ventilators. We've also purchased 270 nasal ventilation devices. And so we've increased our capacity. We've spent 150 million rand doing so, just to improve our capacity during this period. And I'll come to PPE later. Moving on, there was a very important question by Honourable Member Sheikh Iman regarding how are we going to differentiate between public and private. And the truth is that in disaster management, you cannot differentiate between people based on whether they can afford or not. And we will take everyone based on their needs at the time. So this is not about reserving capacity for the private sector or for medical aid patients. If there is a need and the Department of Health wishes to transfer patients into our facilities based on the protocols we have agreed, we will take those patients. And so it really is on a first-come, first-served basis, but based really on need. And the way we need to manage this, honourable members, is to ensure that those that can cope at home and in their own environments need to stay out of hospitals. Hospitals are for sick patients, patients that are going to require...
Dr. Friedland, can you press a button there that shows your video, please?
Yes, sorry.
Press video, then you must be on. Yes, then talk.
Thank you. I switched it off so I could hear better because I was just worried that we weren't hearing some of the questions. So this issue of public and private in disaster management, when you have a surge, falls away. And you really have to treat patients on a needs basis. If the patient needs the bed, they get the bed. You can't reserve patients for the private sector. You have to treat people based on their needs. And that's how we are going to deal with that. I hope that answers that first question. The second one was, how do we protect staff and their families from infection, as I understand was the question. I can tell you that the issue of PPE is an enormous one in our country. Obviously, we're trying to procure as much as possible locally, but we've also had to import. And I can tell you the price of PPE has trebled since the beginning of this pandemic. We have spent just over 900 million rand on protecting our staff, ensuring they have the appropriate protection. Every one of our staff has 3 masks that we give them to use on public transport, in the community and in the hospital. Every staff member has a visor. And then when they come to work in the different zones, we have additional PPE for each of those zones. And that is the way we protect our staff, and we make sure the key issue here is social distancing. Honestly, that's the hardest thing that we've found. Our problem was in the early phase when we had St. Augustine's, COVID spread from a patient who was asymptomatic. We don't have that issue anymore. Our biggest issue at the moment is community spread amongst our healthcare workers. In fact, we think that them being in the hospital is the safest place, but it's when they get into lift clubs or into taxis or in the go back to their own accommodation that they're most at risk. And so what we've now done is issue visors to our nurses and our contractors to wear in the taxis or in the public transport to protect them even further, and also to hand out hand sanitizer, small bottles of hand sanitizer to use when they're coming to and from work. And this is our biggest concern, honourable colleagues. It's not the spread in our hospitals per se that we're worried about. Yes, in St. Augustine's, that's how it spread initially, from a patient that we didn't recognize, and I'll talk to that later. But now it is this community spread that's worrying us the most. In terms of the benefits to staff, obviously we provide full pay to our staff who have to self-isolate. So as you know, if we have a COVID positive staff member, we do a risk assessment of everyone who came into contact, and either they're high risk or low risk, and they have to either self-isolate if they're positive or quarantine themselves. We provide full cover for them. We cover any medical expenses that they required, and we do have a number of staff that are unable to self-isolate themselves because of their poor circumstances or their challenged circumstances, and as a result of that, we pay for their accommodation over the period. So no one is ever prejudiced in terms of that. I think that the biggest issue that we're facing with our staff is anxiety. They're on the front line. They are worried about COVID. And so we're providing free counseling, firstly through our employee wellness program through ICAS. And then we've got counselors in the hospital. Some of them are psychologists, some of them are psychiatrists. And actually that model in some of our hospitals works better because our staff know those doctors and counselors and they feel they can trust them more. So we've had to provide a lot of counseling to our staff. There seems to be in some of our communities a lot of stigmatization of our healthcare workers. You work in a hospital, you've got COVID. Of course they don't, and they feel very pressured about that. So I think that that is a key element here, is trying to, is the psychosocial support. We've also provided vaccines free of charge, flu vaccines to all of our staff to ensure that they don't get flu during this period and further compromise their immunity. I hope I've answered that question. If I can come on to the next one, please. Honourable Sukas, you asked what was the root causes of what happened at the SAN, and was it a shortage of PPE? I'm glad you've asked that question because, I want to just contextualize what happened at St. Augustine's. Was an extraordinary lesson for us. It happened right at the beginning of the outbreak when there were only 7 cases of COVID in our country. And our first case was on the 14th, on the 9th of March. And the patient that got COVID and spread COVID into our hospital was not the patient we were all looking for. At that time, the NICD criteria was a patient who had a history of international travel and who was symptomatic. In other words, had flu-like symptoms or a temperature, etc. The first patient that spread this disease was an elderly patient who came from an aged home who had no travel history. Unfortunately, the night that she came in, which was for a stroke, she was in a cubicle opposite someone who was our very first patient in South Africa in Netcare who had COVID. Now, despite the fact that the emergency department was wearing PPE, somehow she contracted it. And she spread that asymptomatically when she was in hospital. And she was in hospital from about the 9th to the 16th of March. And during that period, she didn't display any symptoms of COVID. She had one spike of a temperature, one single recording, but no one thought that that was in any way related to her stroke, and she was discharged. But unfortunately, she was spreading COVID in a green ward. Now, at the time, the World Health Organization, the NICD, and the Department of Health did not advocate wearing of masks. We introduced that only on the 23rd of March. At the time, we were criticized because it was not according to global policy. That only happened in April. And so the policies were evolving. This lady then came back into the hospital when she was symptomatic of COVID on the 22nd of March. In fact, when we went to the NICD to ask for her to be tested, again, in those days, we had to ask permission from the NICD because none of the private labs were doing the tests, only the NICD, and they had very strict criteria. And they said to us, she doesn't meet the criteria. She may have these flu-like symptoms, but she doesn't have a travel history, etc., etc. But our physician did test her the next day, and that's when we discovered that we had an asymptomatic patient initially who had contracted the disease and spread it. And so we learnt a terrible, humbling lesson at St. Augustine's. And we had an independent investigation by leading epidemiologists from KwaZulu-Natal's KwaZulu-Natal University Research, Innovation and Sequencing platform. They spent a month looking at what we were doing and made 22 recommendations. And I can speak to those a bit later, or I can speak to them now. I know there's a question about the lessons that we've learnt. With your permission, Chair, I wonder if I can raise those now.
We have been flowing very well. Go into them, but don't do all 22 recommendations.
Thank you. Of course not. So, of many of those recommendations, we had already implemented many, had them already, but we strengthened them. And certain ones we were implementing. One of the most important things was around physical distancing. We never realized that our staff, even though we wanted to separate them by 2 meters, were still gathering in canteens and changing rooms. And were eating in close proximity and were sharing food. And so we had to close down many of our canteens and in some of the other areas where we had it to make sure that we had separated out our staff so that they were not coming close to each other, not in the workplace of the ward itself, but mainly in these areas where they were taking breaks and not physical distancing. The other was, of course, hand washing and appropriate PPE. Whilst we issued the masks, what the investigators said was that the nurses, we're all not used to wearing masks, and so we tend to wear it around our necks. And this is critical for all of us to wear the masks all the time. And so we reintroduced and strengthened our training protocols in this regard. We also then divided our hospitals into 3 zones. And a key learning for us is that in the emergency department, you actually have to have a physical division between the red zone, COVID, and the other patients. It's not good enough just to put them into separate cubicles. And so in every one of our hospitals in Netcare, if you have to come to one of our facilities, they're completely separate entrances and they're separate areas with separate staff. And that's what you'll find in the hospitals. We've got 3 zones. The nurses no longer mix between the zones. You can either only work in the green zone or the yellow zone or the red zone. Unfortunately, many of our staff catch the same taxis or transport, but at least in the hospital, they cannot mix in terms of that. The other was around the strengthening. Can you hear me?
Continue, Dr. Friedland.
Can you hear me?
Continue, Dr. Friedland.
Yes, apologies, Honourable Chair. The other was the strengthening of occupational health and safety. And I think, when I reflect on the whole of South Africa, I think this is one of the biggest lessons for all of us, is around the increase of our cleaning regimes. Do you know that we were only cleaning our change rooms twice a day? We now clean it 4 to 6 times a day. We were only cleaning our canteens maybe once or twice a day. We now doubled that. We're now using these invisible ink or these fluorescent markers to check whether our cleaners have cleaned. And so the whole cleaning regime, because of the risk of COVID, has quadrupled for us. And this was a big lesson at KwaZulu-Natal that we were able to quickly implement in all of our other hospitals to say, hang on a second, we might have only cleaned once or twice a day. It's not good enough. We need to increase this. Our theatre change rooms, for instance, we were only cleaning twice a day. We're now cleaning at least 4 to 6 times a day. And when I say cleaning, I'm talking about significant. So at the end of a theatre list, we do a complete deep clean. And we do it on a daily basis. We're now doing that twice a day from a deep cleaning perspective. And so this adherence to occupational health and safety and ensuring our workers are absolutely protected was a very, very important lesson. And then lastly, Dr. Dlomo, Honourable Chair, the biggest lesson we've learned is we have to treat every patient as COVID positive. It doesn't matter if they come in and they're asymptomatic. It doesn't matter if they've had a test and that test is negative. It could be a false negative. And that's the lesson we've learned as healthcare workers, because whether we're at a shopping center or in our own communities, we've got to practice that social distancing. And so we've done a lot of training of our staff over and over again. We have these toolbox talks at the beginning of a shift, in the middle of a shift, to explain to staff, protect yourselves and protect your family by practicing social distancing and hand hygiene. Those were the major lessons that we've been able to share with our Department of Health in KwaZulu-Natal and also with our other hospital groups, and we've been able to implement across the board. I'm going to move on. There was a question from Honourable Chirwa about St. Augustine's, and I've answered that. I think the policy was now about testing of our staff and frequency thereof. We are doing a lot of random testing of our staff on a weekly basis. Sorry.
Dr. Friedland, can you do your last 2 questions, please? And then the rest you will have to send them to us. Do your last 2 replies.
Apologies, Honourable Chair.
I was saying, because of the time factor, take the last 2 questions now and answer those last 2.
Which were the last two? So I'll go to the last two now.
The last two in your list.
Okay, the last two in the list. There was a question about the Northern Cape. We don't have a presence in the Northern Cape. That's why we didn't present it. But we did present the numbers of ICU beds, 131 in the Northern Cape. And then there was a question around, in terms of government negotiation, we put forward what our costs were, and government came back with a tariff. The tariff was lower than what our costs are actually, but we've accepted that in good faith because we realize that there are obviously fiscal constraints at a central level. We were asked by how many numbers of total healthcare workers who've tested positive. We've had 232 healthcare workers that have tested positive. Unfortunately, we have had 2 healthcare workers, one in Gauteng and one in the Western Cape, who've unfortunately demised. And that's the total. Obviously, we have 21,000 people within Netcare, but our total number of staff that have tested positive, fortunately, they've all recovered with the exception of the 2 that demised. So that was 232 and 2 deaths. Honourable Chair, those are the last 2 questions.
Okay. Honourable members, we will forward the questions further if there are any outstanding one. But Dr. Friedland and your team, we thank you very much because as a portfolio committee, we just wanted to be ascertained as to your readiness. And I'm very excited to learn how much capacity you have of the ventilators, of the ICU beds, and your capacity to extend that even beyond what you do have. And your continued discussions with the Department of Health is very important and critical for us. We will forward you some other questions in the light of the time factor, if there are other outstanding. But thank you very much for your presentation. And we would like to leave it at that. Honourable members, I'm sorry if there are some of you who could have wanted to ask and I did not give you space and time. We're rushing against 3 presentations, which I think you agree with us. They were extremely important. There's nothing as comforting as to say the government is going to do so much, but the private sector is willing and is available and is giving support of so much. Thank you very much and good night.
Good night and thank you so much, Honourable Chair. We appreciate the opportunity to present and we stand ready to support the public sector and the rest of South Africa in combating this pandemic together. Thank you for the opportunity.
Okay, appreciate it.
Good night.
Good night. Good night, Chair.
Night, colleagues. Night, Chair.
Good night.
Good night, Chair.
Bye-bye.
Night, Sokacha.
Bye-bye.
Bye-bye, Ma.
Bye.
Bye-bye.
Good night.
Bye, Chair.
Good night. Good night, guys.